Let us learn about the basics of portal flow to appreciate the portal hypertension in cirrhosis. These are my acknowledgements and my notice for you to read. And when you look at this liver, portal vein supplies blood from the gastrointestinal tract, and once the portal vein reaches the liver, it bifurcates and becomes multiple branches, and along with the hepatic duct and hepatic artery, the portal venous radicals form a portal triad that is at the outskirts of a liver lobule, which is the basic functional unit or a composite of units. And from the portal vein radical, blood goes through sinusoids lined by hepatocytes and drains into the central vein. And the central veins merge together and eventually become hepatic veins. So let us see how the flow goes from the portal vein to the central vein. It is a slow trickle that goes down to reach the central vein, and then all the central veins join together to become hepatic vein branches, and ultimately 2 or 3 hepatic veins enter the IVC, and the blood leaves the liver via the hepatic veins IVC to the right atrium. So this anatomy is critical to understand what is normal flow. And for normal flow, we need a pressure gradient from the portal vein to the IVC. Unless there is a gradient, flow doesn't happen. And that gradient is the difference between the portal vein pressure and the inferior vena cava pressure or hepatic vein pressure is known as IVC portal vein gradient or hepatic vein portal vein gradient. That gradient is quite small, less than 5 millimeters of mercury. Think about your normal blood pressure. Systolic is 120 millimeters of mercury, diastolic is 80 millimeters of mercury. In the portal venous system, the gradient is very small, less than 5 millimeters of mercury. So, when you see patients who develop problems in this route, either in the portal vein or in the liver or in the outlet to the liver, hepatic veins and IVC, whenever there's a problem that leads to resistance to the portal flow. And when there is resistance, then what happens? The pressure gradient increases between the portal vein and the IVC. And when the gradient is more than 5 millimeters of mercury, that's when you diagnose that patient as having portal hypertension. So we looked at the normal flow. We looked at problems that can increase the resistance. And when the resistance increases, the gradient increases above 5 millimeters of mercury. And that's the cutoff to diagnose portal hypertension. And we learn a lot about why these areas of resistance develop. And I would like to thank authors of this beautiful guideline statement, and that helped me to develop this material. And thank you.